Hi, my name is Dan Gomez, and this is Mental Health Supra Omnia. Mental health above all. We identify and understand mental health issues and the paths for help. Eating disorders in sports. Is it just wrestling and gymnastics? Because that's what I thought. But to understand the medical and mental health issues in a much more granular level, we brought in the expert, Kendra Becker. She's the Director of Translational Research, Eating Disorders Clinical and Research Program at Mass General Brigham. She's also the Director of Psychology of the Women's Sports Medicine Program at MGB. And finally, she's an Assistant Professor of Psychiatry at Harvard Medical. Kendra, before I ask you a question, let me just say, I may have used an unfamiliar phrase to some of us, translational research. So let me just say what translational research does, and Kendra, you can correct me, is it takes basic discoveries and turns them into practical real-world solutions.
That's
so
exactly
Kendra.
Right.
Kendra, let's start by having you give us a short overview of your research, particularly as it relates to emotional and personality influences and the neurobiological elements that we're talking about relative to eating disorders.
Absolutely. Thank you so much for that introduction. And I'm glad to talk a little bit about what my research primary focus is. So I like to distill it down and think about what I'm trying to do across all disciplines, whether that's neurobiology, emotional functioning, or personality traits, is look at what I call and what kind of the field thinks of as maintenance mechanisms. So what do I mean by that? I mean, what are the things that keep behaviors going when they're not serving a person anymore, when we might think of them as maladaptive because they're causing some kind of, distress or medical consequence or psychological consequence? Why do they keep happening? For eating disorders, why is it so hard to kind of understand, how much food one needs to eat? What is the, relationship between, or why does compulsive exercise kind of go hand in hand with restriction? What drives these behaviors? So I'm looking at all of these different modes of measurement to try and understand the why. And that's also led me, as I have been in this space for a longer period of time, to look at why does treatment work? What are the mechanisms that we can intervene on that disrupt these behavioral processes? And I like to look at neurobiology because I think it's really compelling. Honestly, I think it really gets at the question of, not just why does something happen, but it really starts to poke at that long-held belief that people are just choosing behaviors that, don't serve them. It helps us understand there's an important brain-body connection, and that a lot of times these are really difficult, if not, really impossible to do alone behaviors to change. So I think it really validates folks with these conditions, and also their family and friends who can't seem to understand what is going on. Why is this so hard to change?
So before we bring in Kathryn, I just want to ask you a quick question. You have a background, if I'm not mistaken, in running, maybe even in dance. Did you see it in your life, in others? Did you see problematic or disturbing behavior, eating disorder behavior, something along those, something that was maybe shocking to a young woman?
I definitely experienced different messages and had people who were close to me who struggled with different eating behaviors or thoughts about weight and shape, or belief systems about what the body needed to look like in order to do well in either dance and or running. So these messages came up in my history as a dancer, and then also as a long distance runner.
Great. So I said we were going to bring Kathryn in. Kathryn Lodwick-Jones is an LPC. More importantly, she is the lead for the Eating Disorders Center of Excellence at Equilibria Psychological. Kathryn, as you've gotten into the area of eating disorders, because obviously we didn't study it in grade school or high school, maybe at college, but from a professional perspective, you've gotten into eating disorders and spent a considerable amount of time there. Were you surprised by the pervasiveness of eating disorders in sports?
I was, and I have to say, I have not worked professionally with many athletes. in the eating disorder space, but I do have a lot of personal experience from peers in college and growing up in the dance and athletic space who did have eating disorders. And only until I became an adult and a professional did I reflect on, oh, I didn't realize that was what was going on.
Yeah.
But now I think I'm less perhaps surprised at the prevalence of eating disorders in athletes and more surprised at how we often overlook how they show up in the general population, treating clients who you wouldn't traditionally see having an eating disorder as manifesting a lot of very similar symptomatology or presentations.
Right. Now, we've spoken to others and had others on the podcast to talk about eating disorders, and we've even brought up sports in particular. I know we brought up wrestling, we brought up gymnastics. But Kendra, one of the things that got us interested in talking to you is that we found out that eating disorders were much more pervasive. And you were mentioned, if I'm not mistaken, in an article about about eating disorders in things like even Division I basketball. So we were surprised. And so I'd like you to tell us a little bit about the prevalence of eating disorders in things other than gymnastics and wrestling.
So thanks for that, because I think it is, and for bringing awareness to this topic, because I do think folks have often thought, oh, well, if you're playing ball sports, you're protected from having an eating disorder.
Right. You have to be like fast. You have to be strong.
Yeah, you
be
have to,
agile.
like, it's about the team environment. There's not so much pressure on the individual. Like, this shouldn't, be as high of a, pressure cooker as some of these other sports. So I just want to say that there's a lot of research that is needed in this area. So as far as the exact percentage of people in like team sports who have an eating disorder, that would be hard for me to say. But I can tell you all that, the prevalence of eating disorders in athletes like ranges from, maybe the low end of 18%, which is still much higher than the general population, all the way up to about 45% of women in sports having some eating disorder, and around like 8 to 19% of men, which is extremely high when we think about, the general population estimates for where men might land as how many men might have an eating disorder. And I think it's also really important to think that up to 32% of collegiate athletes, which is not just, runners or gymnasts, this is all collegiate athletes, have an eating disorder, and collegiate athletes are 3 times more likely to meet diagnostic criteria than a non-college peer. So again, I can't tell you specifically what the percentages are in each individual ball sport or something like that, but overall, it's a high prevalence. And I think, if part of the question is what's going on in sports, don't they bring a lot of like good things like, sportsmanship, and especially ball sports, like working together as a team. I think what's important to remember, and I'm happy to talk more about it if that's where the conversation goes, is that athletes live in the same world we do. They have all the same pressures and same risk factors that people who are not athletes are also managing. And there are certain specific factors of a sports environment and this athletic mindset that can increase risk for athletes across sports. And that athletic mindset and that sports environment are not specific to wrestling or gymnastics. And so it's, when we stop and think about it, it's not that surprising that sports in general have, some additional risk factors that put people, perhaps at, some individuals at a higher risk for developing an eating disorder.
Well, I don't know. I'd say I read the paper, but nobody reads papers anymore. I read the news. I read the news. I read articles. When I think about women's basketball, particularly women's professional basketball, there are a number of superstars out there now.
Yeah.
Okay? People know their name, okay, or names. They know their names. These don't. I'm not trying to comment on their bodies, but these are people that play the sport pretty well. Like, I find it hard to believe that in basketball or in some of these other team sports, how is it that it can be more pervasive? What are they trying to get? I don't understand why. Like, it doesn't seem to be conducive to the exercise you need, or the energy you need, or the speed you need, or the agility in order to shoot the ball?
Mm-hmm. That's an excellent question. I think important to remember is that eating disorders distort thinking and understanding of kind of data or things like that. So just keep that in mind. And then remember that all of those things that you just mentioned, speed and agility, are also important for non-ball sports, like track athletes and gymnasts. And like, so that it doesn't, like if we were to just look at, logically, what does someone need to do these sports in an elite level? An eating disorder is never going to make sense for anybody, because it is going to break down the very kind of muscular structure, bone density, et cetera, that keeps people able to do these activities and erode their confidence, like the ability to sustain performance under pressure. So that would be true across all athletes. I think what's important to remember for, even sports like basketball, is that, this athletic mindset, especially as you get better and better in your career, like really encourages things like determination and like sticking through pain and like pushing oneself to the max, and like this hyper focus that you see as people get into elite sports, and kind of this mentality that like, whatever, especially if you've got a strong athletic identity, so someone really sees themselves as a basketball player, like that's who they are. They're putting in a lot of themselves and willing to, go like pretty far in putting in time, effort, health into reaching their goals. And if an eating disorder gets a hold of that, like that can mean things like, well, you'd be a little bit faster if you were a little lighter. You'd get a little bit more attention, maybe get folks a little bit more interested in your profile, get you a little bit more attracted to collegiate recruiters if you looked a little better, right? So you have this voice that like really can start to hang on to the traits that make these athletes as successful as they are. And that's what's so insidious and awful about eating disorders, in my opinion, is what it does is it takes these traits that we generally think of as really great, like, striving to be better, like I said, this kind of like intense focus, and can corrupt it. And so again, I think, if there's that, plus there's any messages in the sports environment about things like, needing to be leaner, or there being a specific body type that would be best for that particular sport. Obviously, those messages are going to be really strong with certain activities like lightweight rowing, where you have to be under a certain weight, or wrestling, or gymnastics. But I think in general, these messages exist where people are thinking, if you had just this extra edge, you could be just a little bit faster or a little bit better. And when you're in an elite level or college level, those seconds matter. So people who are really invested in this and really have a strong athletic identity, they're thinking, I'm going to do whatever it takes. And the eating disorder can sneak in that way. And folks don't necessarily even know that they're engaging in eating disorder behaviors, like thoughts about, I'm going to eat a little bit healthier. Like if I eat this, it's going to slow me down and make me like too heavy for my race. And so there's a lot of messaging about like what people should and shouldn't eat. So athletes are trying to, like the rest of us, make sense of a lot of information, and they don't always have great resources about what do you need to eat to fuel your body at this level of competition.
Interesting.
I think it's also important to note just the level of pressure on all athletes, right? It is, when I think of gymnastics and wrestling and dance in particular, we think of these as kind of aesthetic sports where you're oftentimes in a way showcasing your body and there's pressure to appear a certain way. But even in basketball and ball sports, there's pressure on the body to function in a certain way. And we know that eating disorders are triggered by high stress environments. And so athletes are under an excessive amount of pressure to look or perform in a certain way. And then what I appreciated what you brought in earlier, Kendra, was athletes are people who live in the same world that we do. So if your regular person is experiencing negative ideology or information about how they should look or what is functional or attractive, athletes are under the spotlight. And particularly for women's sports aren't taken seriously. So there's extra pressure on conforming to what does a woman's body, what is it supposed to look like? And how can it also somehow balance performing at an elite level and not letting people down, not losing your career, not losing your sense of identity?
Mm-hmm.
Do either of you see differences in presentation between people who have eating disorders that are active in sports and those that are not active in sports, or are they the same? Do they present the same?
That's a good question. I think I've seen both. So let me kind of give that answer with kind of a two-pronged approach. So some athletes with eating disorders present very similar to people who do not have eating disorders. And the kind of mentality of the eating disorder is super strong. It's a really strong voice. They're really worried about kind of, the same things, and their athletic identity has kind of fallen by the wayside. And in my mind, with how I'm conceptualizing those folks, is that they're kind of like the eating disorder mindset is first. And it's kind of driving the bus by the time I'm seeing them. Other times I see athletes who maybe at a similar weight, like if it's a restrictive eating disorder or something, they may have similar medical compromise, but their athletic identity is still really strong. So what's happened is like the eating disorder has started to encroach a bit on that athletic identity. And so, they're thinking, I really want to be the best basketball player I can be, or I really want to be the fastest runner I can be. And those folks are a little bit different treatment-wise, because if I can start to separate out that, the factual information we've been kind of touching upon today, that you actually need a lot of fuel to be a excellent elite athlete, then I can start to pit the athletic identity against the eating disorder. And I'm going to do that in treatment if I've got both of them present. So it's adding more so than doing something completely different. I'm going to talk a lot more about, why is the athletic identity important? What is it that, they want to do with their careers, and doing some, thought questioning, like, how are we getting there if we're burning muscle instead of building muscle? How are we getting there if our bone density is getting less? So I'm putting I'm framing the questions to pit those two identities together. But there are athletes where the eating disorder identity is just really strong. And so I'm treating them, the exact same way as I would someone who does not engage in sports.
I agree with that. And I find that it often depends on when the level of intensity of the athlete part of the identity started happening in this person's life, right? Was their family culture around, we expect you to excel in sports, and that kind of got you there from a very, very young age, right? You're a 3-year-old playing soccer and a D1 athlete, or is your athleticism or being an athlete a huge part of your identity, but you have some other parts of yourself that are also equally valuable to you, or you kind of only got into sports and happen to be very talented, but you only started sports when you were maybe already halfway through puberty, and you're just this very elite person, but you're a student athlete, you're also studying other things that feel like that can impact your self-esteem more positively compared to how the eating disorder is interacting with your athlete identity.
So, Kendra, you mentioned bone density, and a lot of times I'll focus more on the the mental health aspects associated with with different modalities, CBT, DBT, all that. And I know we're going to get to that, but you mentioned bone density, and I just wanted to let you know, you have a lot of articles out there. Normally I'll read people's books or whatever. In your particular case, you have over 70 articles out there. I did not read all 70, but I did read at least 10. Okay. One of them in particular, if I'm not mistaken, actually spoke about bone density and the differences in bone density between people with eating disorders and people that did not have eating disorders. And I believe it had to do with ARFID, if I'm not mistaken. What is the importance of bone density? So as for the layperson, for me, for my wife, why do I care about bone density, and how's bone density impacted here by eating disorders?
Excellent. All right. So bone density is essentially, if you want to think about it visually, which I like to do because it just kind of helps me understand like why this is important. A healthy bone has what we think of as like a really complex microstructure. So when you were to look at that in an X-ray, it's going to look really dense. You're going to kind of, be able to notice that there's not a lot of space in between the fibers of a healthy bone. If someone has a low bone mineral density, you're going to see holes, kind of like places where the fibers are less dense, and it starts to look a little bit a little bit, more, just a lot of more black space, if you want to think about an X-ray for me. Now, what does that mean? That means that if there's pressure or force on the bone, it is going to have a lot less of those fibers resisting breaking. So what happens if you have a low bone mineral density is your risk for injury is going to skyrocket. And this obviously is important to athletes, because if they get injured, especially we're talking about people at like peak transition times, right? Like moving from college to maybe pro, or maybe from high school to college sports. Like, and again, if we're talking about somebody who really cares about staying in their sport, this is a big, big deal, because if you get certain injuries, you're out for a season. You may lose your spot on a starting lineup. You may lose your chance at an endorsement. Like, injuries can be huge, and they can take people out for a long period of time. Now, why does the rest of us care about bone mineral density? Because again, these injuries can be really problematic for our daily lives. And if you think about some of the places we take bone mineral density in that paper, includes your spine. And so what you don't want to do is have low bone mineral density in your spine. I mean, what I usually tell my adolescents, because they really don't like this, is that like, that's what leads to the hump. Like, when you think about people who are really old and have like the hump, that is micro breaks all on their spine. And so when you're thinking about like, especially if you want to kind of challenge the eating disorder, like if you're trying to look a certain way, I imagine it's not having a hump. And so bone mineral density is just really important. And so I like to really highlight, that what we show in that paper is even adolescents who start to lose weight and haven't even reached our thresholds for low weight are already showing problematic bone density at key sites, including the hip, the spine, and sometimes the femoral neck. So like, what you're thinking about then is like, these are really important parts of your body that are already potentially compromised. And if someone's lost their menstrual cycle, this is part of what folks think about as the female athlete triad in the past. And now we think about it more as REDS, which is relative energy deficiency syndrome in sport. What that means is that, if you have if you're not getting your cycle, if your cycles become really irregular, you're compromising your bone health even further, which is, again, super important for athletes and adolescents, because you only have until you're about 20-ish, maybe 21, to build your peak bone density. So if you don't reach that nice, really like strong kind of microfiber or microstructured bone that can resist injury well, you are not going to reach it. Like, you're going to get to 80%, and that's the only, for the rest of your life, you're going to be at 80% if you eat well and recover, which means once you start aging, which all of us do, you lose bone mineral density as you get older, and women lose it through menopause. You're not starting from 100%. Starting from 80%, which means your risk for osteopenia, osteoporosis, breaks from even doing things just like, a simple fall, really high.
So I'm glad you brought that up. And in particular, I'm glad you brought up osteoporosis and the hump. So fundamentally, correct me if I'm wrong in my thinking, what happens here is we're bringing an older woman's bone strength, and we're bringing that down to someone that's much younger, 20, yes, 24, whatever, which I'm sure no one wants. When you talked about the hump, I liked that as well. Correct me if I'm wrong. In your research, you also sometimes talk about food triggers, and how that impacts eating disorders, how that impacts other things associated with treating eating disorders. What are some of those triggers that we need to be looking for? Is there things that we can do that help us or to hurt us? I know you did a lot of research on ghrelin as an example, and maybe you might even want to explain that word for us.
Yeah, what ghrelin is?
Yeah.
Yeah, ghrelin is one of the, if not the, I should say the primary appetite stimulating hormone. So it's a hormone that tells your brain, hey, I'm hungry. And it's usually on a like a kind of predictable circadian rhythm. And this is why in treatment, we have folks kind of work towards eating every 3 to 4 hours, because that's what your ghrelin level should be doing. In someone who's never had an eating disorder, it should be rising, being like, oh, it's time to eat. And then when you start to eat, it falls down. And you want to see that kind of like a nice pattern, helping people who are in recovery start to eat more normatively. And then your body's working with your brain. So that's ghrelin functioning well. In certain conditions, we see that disruption because of eating behavior. So in anorexia nervosa, for example, ghrelin levels are very high, much higher than people who are healthy, even in a fasted state. So they haven't eaten for 8 hours around. You would expect ghrelin levels to be high, but for those with anorexia, they're even higher than those who are healthy. So like really the body is saying, I'm hungry, feed me, but it doesn't reach. It's like there's almost kind of true misalignment because it doesn't prompt eating behaviors in people with anorexia nervosa. It's chronically high, and there's like some kind of either it's like a signaling problem or there's some kind of like inability for like the messaging to get to the right kind of areas of the appetite regulating areas of the brain. But regardless, what we see is kind of consistently throughout the presentation in youth and in older folks with anorexia, you get high levels of ghrelin. What was surprising is when we were talking to people who had low weight ARFID, and for those who may not know what that is, it's avoidant restrictive food intake disorder, which is an eating disorder that is not characterized by fear of weight gain or getting fat or kind of changes in weight and shape. It's people who don't eat enough because they have really selective sensory experiences around food. So like certain taste, texture, smells, appearance are overwhelming, or people who are really afraid of eating because they're afraid they're going to have like GI pain or an allergic reaction, or they're going to throw up, or they're going to choke, or there are people who just don't feel like they don't remember to eat. Eating is a chore. It's a burden. And those people, if they're at a low weight place, what we found is that their ghrelin levels are they're significantly lower than anorexia, which is weird because they're all low weight. So the people with anorexia and the people with low weight ARFID are all low weight. There's no difference in their weight status, but the people with ARFID are showing kind of almost a flatlined ghrelin level. So like it is way lower than the people with anorexia. It's not significantly lower than healthy controls, but it's numerically lower, which is again strange because these people are, not getting enough food, and they're in a fasted state, and their ghrelin levels are not kind of kicking up like they should be. So when they're telling you, I don't feel hungry, there might be some, again, neurobiological kind of body reason that is helping support that symptom. What I thought is like, this is very validating for people who have this presentation of ARFID, because it's saying like, it's not the same as anorexia. It is a different condition. And when our patients are telling us, I don't feel hungry, they're not. So I thought, again, this kind of idea of like using neurobiology to help us understand symptoms, finding the mechanisms of what is behind our patient's symptoms, to be really important for both the treatment and the, kind of understanding of psychological conditions like eating disorders.
So let me ask you both.
Yeah.
You both present information. When you're working with people, you present information in addition to other things, in addition to trying different types of therapy. When you're presenting information, is there a difference between the way athletes take in that information versus non-athletes? Does just the presentation of information cause athletes to potentially change their behavior in certain instances? And is that true for non-athletes, or does information not matter?
I think it depends on the person and the personality, certainly. I won't generalize athletes, but oftentimes because there is such a high connection to that part of their identity, you have the benefit of having the common goal of being motivated by, I want to continue to succeed in this sport, and having more of a frank conversation about, okay, we both want you to be healthy and function and succeed in this sport. This is what can we do together? This is what we need to do to help you reach that goal and also be in recovery. And I think, not to say that it's more challenging with someone who isn't an athlete, but there is a little bit more internal work to explore. What is your why? What is your motivator? What other parts of your life will help you feel connected and fulfilled enough to want to recover? So there is a little bit more general, what we would call psychoeducation, which is talking about the functions of therapy and eating disorders and how we can recover. That, not to say athletes already have more access to psychoeducation, but they might be a little more motivated with specific facts or details about what might be helpful.
I've really liked what you said there, Kathryn. I think like oftentimes when we're working with somebody in order to, get them to, consider the hard work of recovery, because I think it's important to mention that recovery is very difficult. It's a lot of work, and, I'm an outpatient provider, so I get someone for 50-ish minutes a week. I'm giving them ideas and things to consider, but they're doing the work. Like, I'm not taking credit for anybody's recovery. They did that. So, in that sense, it might be different if you were talking to somebody at like a higher level of care, like residential or partial hospitalization or something like that. But I think for me, I'm doing exactly what Kathryn said. I'm kind of getting the like, why are they here? What is, motivating them to be willing to sit with me, even if it's an adolescent who's there because their parents are making them. Like what is it that drives them? And then I can present the psychoeducation that's going to be really helpful. So like for athletes, there's some things that I'm generally going to, like generally, I think people really don't know that if you're not eating enough and you are thinking you're doing strength training, if you're in low energy availability, you're not building muscle. Your body's going to break that down. And why? Because muscle is very expensive to keep up. So like if you're not feeding it enough, then it's not going to want to expend that, kind of resting metabolic energy to keep the muscle there. It's going to break it down because that saves energy. And I don't think a lot of people know that. They don't know that to build muscle, you have to fuel your body. And so I'm going to go to that, or I'm going to go to bones, especially if I've got an athlete who's already got an injury. I'm going to talk about, if they want to stay in their sport, we've got to get them strong enough to do that. I'm going to talk about, sometimes I even talk about like my own history with injury, like an ACL tear, like, things I didn't know that might have actually helped me avoid that injury. So I think with people who are not athletes, I might be talking about like, well, what are you noticing about your concentration? What are you noticing about like, if it's a student, like how easy it is for you to, stay awake or be able to kind of access the parts of your brain that you need to be able to focus for long periods of time to do well in your studies? Or what about your friendships? How connected are you socially now? Like, what are you choosing not to do because the eating disorder is driving you to do something else? What are you missing out on? And so I'm looking for things that would help someone, feel engaged enough and have a reason to do the hard work of recovery. And so that question is the same for everybody. It's just with athletes, it's usually, as Kathryn already mentioned, something that is, especially if they have that strong athletic identity, going to be kind of easy to find, well, this is going to keep you out of your sport. And with athletes, I always tell them, I don't want to take them out of their sport. I absolutely do not. I think if they like love it, it's part of their identity, they have connections, and like, I don't want to do that. I want to help them find a way to stay healthy enough to stay in their sport now, continue to get healthy enough to then play it as long as they want to. And I think that's a message that sometimes can be really helpful to hook athletes, because they kind of expect that if they're coming with an eating disorder, that someone's going to immediately say, well, you're going to have to step out and you're not going to be able to play again.
You mentioned making sure that you're eating enough food. And recently I shifted from doing Pilates to doing strength training. And the first thing the trainer says is make sure you're eating enough protein and all these things. And he tries to build the in my head, the reasons why, which I certainly paid attention to for at least 30 seconds of that. That said, there is a I know it's terrible, Kathryn. you could tell me how bad I am later. There is a substantial difference in the number of calories that an athlete eats during training and what anybody else might eat outside of training. What does that look like? And what's the people with the eating disorders, do they not eat that higher amount? What happens here?
So it's so I'll start at kind of answering like when someone's in recovery, because I think that might be a helpful place, and then we can kind of go into like what athletes generally need. If someone's in recovery, I like to remind them that they're not just eating for their sport anymore. They are eating for recovery too. So they're eating for 2 jobs. And if they're an adolescent, they're actually eating for 3, because their body is also rapidly developmentally changing, right? So when we're thinking about the calorie needs of that, you're not just fueling one thing. You're fueling, 2 to 3 things. And athletes in general, they need to consume additional calories around their trainings and workouts. And so I'm not a sports nutritionist. So if it's an athlete, I am always using my sports nutritionist to help me think about what each individual needs. But essentially, like, you need to be fueling pre and post workouts. And the longer the workout, the more components need to be in your fuel. So like you often need to have a carb plus a protein if you're doing something like 70 to 90 minutes. So like thinking about like, this isn't just 3 meals and 2 snacks. If you're going on a 2-mile or a 2-hour run, you need a lot of fuel for that. And you're going to need to fuel during that sometimes. So that's just normative. But when we're talking about people who are in recovery, I often remind them of this shift in, their metabolic rate. Their body started to go into, they were losing weight, and then they kind of hit a place where they stopped losing weight because their body started changing to prevent further weight loss. Then maybe they restricted more depending on what kind of, eating disorder they might have. And then perhaps we're looking at somebody who's, because of their irregular eating patterns, their body does not trust them anymore. So it shut a lot of stuff down. So bone density, and it's probably started to steal from other places like brain health, bone health, muscle health, etc. So you're in debt. You're in caloric debt in an eating disorder. So if you're going to start to rebuild that, what you need to do is remember that once you start giving your body the, kind of fuel that it needs, what often happens is then all of your little construction workers in your body go back to work all at once, and they start working overtime. So you go from being low metabolic rate to being like hyper metabolic, especially youth with restrictive eating disorders. And what that means is that in order to gain weight, you're going to have to eat substantially more, because your body is trying to pay back its debts and fuel you and pay for your athletic kind of engagement. So we're looking sometimes on the upside of 3,500 to 4,500 calories for a young girl. And so I think people are often very surprised by that number. It's like, and again, oftentimes we see, is this enough? Do we see the weight starting to go up? If not, then we keep adding, because what that's showing is the body is using it, but you owe a lot of systems a lot of calorie debt. And what I always tell people is we don't just want to get you to a weight. We want to get you to a place where your body is functioning as if it did not have the eating disorder, which is a longer investment. And it is a lot more time eating that immense amount of food than people anticipate too. They're kind of thinking, oh, well, once I get to this weight range, I don't need to eat this way anymore. Not true. You're going to have to eat that way for a good bit of time.
Interesting.
I use this analogy with clients in doing the psychoeducation about the importance of fuel as kind of imagining your body, your whole body, this sounds ridiculous, is a muscle. And that, when you're working out, if you don't do the warm up, the pre-workout, you're going to get injured, right? The warm up is fueling yourself to prepare you for that heightened state. And, if you've done strength training or really done an intense warm up, there are micro tears in your muscles. And if you don't recover, if in an hour the next day you do another workout, you're going to injure yourself. And eating to give yourself enough calories to be able to do the workout, and then also eating after to recover so that you're not in starvation, so that you can actually warm up and work out again the next day, is very similar to the process of warming up and recovery. We have to eat before and after to fuel our bodies in a cycle.
Fascinating. Now, Kathryn, I know that when I've spoken to you in the past, I've heard you talk about CBT and DBT, and Kendra, I know that one of the 10 articles, at least one of the 10 articles that I read of yours, specifically called out CBT and DBT in some of the research. Okay, do me a favor, first, very quickly define what is CBT, what is DBT, and are those the two things that the two arrows in the quiver that we use to go after or to help help with eating disorders, or are there others? Kendra, go ahead.
Okay, so I will say that they're the two I have in my quiver. So I want to be completely honest that, there are folks who do different treatments. And I think, like I said about like research in athletes, like research in treatment and how other treatments work, we need more of it. And often it's because it's a little bit harder to study than CBT. CBT lends itself very well to scientific investigation. It's very much like, here's what we're going to do. Here's what we think is the mechanism. Are we seeing it change? So like CBT lends itself very well to that. DBT does as well, but it gets to be a little bit trickier because there's a lot of components to DBT and it's a lot longer traditionally than CBT treatments. But I just want to put out that disclaimer. There are people who see eating disorder patients in other modalities than what I use, but I use CBT and DBT, and CBT stands for cognitive behavioral therapy. And it's really about understanding, essentially how thoughts influence how we feel, how feelings influence how we think, and how both of those things both influence and are influenced by what we do. So like this idea that there's a triangle, we have feelings, thoughts, and behaviors, and all of those things are influencing each other. So the good news is we can intervene on those different kind of points and see how it affects the system. So for example, like with an eating disorder, one of the core tenets of CBT is that you are looking at like the relationship between what you eat via tracking what you eat and what your weight does. And you're seeing, are the thoughts that you have about rapid weight gain or about not being able to maintain your weight if you're not low weight, is that true? You're doing basically like scientific experiments is kind of how I like to think about it. You put on your scientist hat and you're like, are we going to change this? If I eat cake every day, do I gain 10 pounds? And so you're doing that on purpose, setting up experiments and kind of noticing the relationship between weight and food. And, you're setting up experiments about, is the way that, you think about your body the same way that other people think about your body, that type of thing. So that's CBT. DBT has all of that, but it adds, what, in the past was called like the like next wave of interventions, which really is about this idea of acceptance and validation. So DBT adds what may seem small, but is actually a huge set of interventions about validating the kind of internal wisdom that somebody has, like understanding that like, okay, this makes sense that this behavior and this disorder developed, giving all the things that were happening around, like it seemed adaptive at this point of time. Like it makes sense that people who, are in a world that really values thinness and they maybe have certain genetics and maybe they're an anxious person and they're in a high pressure environment, how it would make sense that like weight loss would be a good idea, right? So like it validates people, it helps them kind of see, kind of align with the patient in that way. And it also teaches them a language to validate themselves, right? To not be so critical and harsh, because I have not found that shame is super motivating and helpful for anybody. So DBT does a really nice job of validation of, kind of other people and yourself. It also adds this idea of acceptance, which is this importance of like basically being aware of what is and noticing it at this moment, these are the facts, so that if you want to change that, you can, but you're changing from a place of what is versus what we may think of what should be. And I think, again, that seems like a very small shift, but it's actually really important to think like, it should be easy for me to eat. It's not though. And so like, if we just accept that it's not, then what are we going to do about that? And having that language be, relevant for not just the patients, but sometimes the patients' families, to start to really think about, okay, well, if we just accept it's a fact that like this isn't easy, then what are we going to do to make it easier? So it shifts the lens from, kind of thinking about things that aren't possible to just change by saying it should be so, and giving people new opportunities for intervention. And then Kathryn, like, please add to whatever.
Yeah, I agree with all that. And CBT and DBT are the primary arrows in my paper as well. I think that they are two of the most studied theoretical frameworks in our field. And that's not to say that they're the only and the best or will always be that way. That's just CBT, I agree, is very easy to research. It's more tangible than some of the other therapeutic approaches. But anyway, I think that it's hard to approach eating disorders without both of these tools. If you're going to commit to using one of these approaches, they really pair together really well, because CBT is very tangible and it can look at really specific, what I would describe as quantitative aspects, whereas DBT is coming in and is a little bit more qualitative and relational, right? We can do some CBT work and look at your thoughts and your feelings and behaviors, but DBT is really looking at how is this impacting you, right? You might assign this, I'll call it therapy homework, of working on this thing between sessions. But if you don't have the ability to tolerate the distress that comes up from making these changes, then you're probably not going to make progress, or you're going through the emotions and going through the motions without being able to manage your emotions. And we're not robots. We're not trying to program you to get from point A to point B. We want you to live your life and implement these changes in a way that's actually human and sustainable.
Interesting. I'd like to ask a series of very directed questions to either one of you, as the case may be. But Kathryn, I want to start with you, because you talked a lot about, you ended up talking a lot about some of the tools that you need. When I think about therapy, most therapists are not specialists. Most therapists are, in fact, generalists. Okay, you're 10, yeah, I'll see you. You've got anxiety. You're 70. You're worried about whatever it is you're worried about. Yeah, I'll see you. Other people are more specialized. If you have an eating disorder, or if somebody in your family has an eating disorder, how do you find the right therapist? What questions should you be asking to find the right therapist that's going to be able to help you?
I've used this answer before. It really depends on the situation, right? And it's, you have to kind of be an open-minded specialist in yourself or your loved one to find the right specialist. And what I mean by that is, let's say that we know that a therapist who has at least 10 years of experience in DBT is the most effective for this age range or population. That doesn't mean that's going to be the right fit for you and your family. So it does take, I think, like any situation, but especially with eating disorders, where there's long-term recovery and a lot of support needed, it takes some shopping, for lack of a better term. Finding someone who certainly has specialization in your demographic, right? Maybe you're a 14-year-old female or a 40-year-old male, but being able to have a conversation with that person to see, what can you offer me that you think would be helpful? Having that collaborative conversation. I also think just kind of gold standard is a clinician who does have some experience in evidence-based practice, even if it's not specifically CBT or DBT, maybe it's CBTE or family-based treatment, or they've had a lot of experience in different levels of care, so they understand how they can support if you do need a higher level of care. And then secondly, they have experience working with other parts of a treatment team, whether it's a dietitian at the least, but also a primary care provider or pediatrician or psychiatrist, because really you don't have as much success if you're not working with a comprehensive team. Whereas other presentations, you might be able to really recover in your challenges with just an individual therapist.
Thank you. Kendra, let me ask you, what do you want student athletes to know?
That is an excellent thought. So I think if I had to say a couple of things I want student athletes to know is that kind of that statement I said before, that like we're all living in the same world and have a lot of the same stressors. And so just because you're an athlete doesn't mean that your mental health is supposed to be perfect. Like, I think for a long time we've been fighting this myth that like because athletes exercise and exercise builds endorphins, athletes are just happy all the time. I think like recognizing that like, yeah, there's a lot of stress, especially with student athletes. They're basically doing two jobs. Like they've got their athletic performance and their academic careers. And like a lot of times those are very closely linked. Like they have to be doing, well enough in school to be able to play their sport. And they have to stay, able to engage in their sport at a high enough level, getting enough sleep, blah, 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 so that they're actually, performing well enough to get playtime. So these things are really closely linked, and just understanding that like mental health is one of the most important things about athletic performance. I feel like, a lot of times I love the Olympics because it makes all of my statements feel like so true, because nobody's ever going to argue with me that an Olympic athlete is an elite and very good at their sport. And I say, a lot of Olympic athletes talk about the importance of mental health, and also what sets apart, the person who scores, who comes in 3 seconds faster than the other person. A lot of it is like confidence and like kind of managing that immense amount of pressure that athletes face, that Kathryn's already spoken about, the kind of like pressure cooker of being, on everybody watching you. And so I think that's really important, that like mental health is important for athletes, and that we all live in the same world and we're all facing a lot of challenges. So like that, number one. Two is that, especially for athletes, understanding your body's needs to perform at that level from a nutritionist, like getting even just a consult to be like, this is what I do, about how much, fuel, like what you were saying, your trainer was giving you some information about, understanding that, because a lot of athletes start off a certain subset, I should say, start off not thinking I need to lose weight. They start off thinking, I want to fuel better for my sport. I know I need to eat more protein, so I'm going to shift all these carbs to protein. And they don't understand that like their body needs all of those things, or that carbs are actually part of what's really important to staying hydrated. And sports nutritionists really know how to give that information in ways that can be understood and appreciated by athletes. And we could avoid some of these backdoor ways into eating issues if athletes got real information about how to fuel their body, and that if they fuel harder, they eat more. Like that kind of equation that seems like it makes a lot of sense on the back end of something, but when you're just trying to navigate how to play your sport, or how to go from a high school athlete to a college athlete, which is a lot more training, I think that would be the two messages. Understand what you need to fuel your sport, and remember that just because you're an athlete, like everybody is living in the same world, and that there are unique pressures that athletes, may need some additional support around.
Okay. I'd like to ask each of you a question about the role of families, but I'm going to ask different questions to either of you, to each of you. So Kathryn, we talked about interviewing therapists. And I liked the tips that you provided, but sometimes people don't realize that they need help, but they get clues, or other people in their life understand that there's something wrong, and maybe there needs to be some sort of an intervention or help given in some way. Sometimes that comes from families. What is it that a family member will see or should be looking for to identify, to be able to set up a discussion where you could say, is something happening here, and how can we help? What should they be looking for?
You're asking for what are some potential warning signs a family member might
Yes, I am.
notice?
Yeah, but see, that's like way too few words. I had to use a lot more words than that.
I want to make sure I understood the question. Yes, it's relative to how you know the person, right? And I think that if there's any significant change in their behavior, and particularly with eating disorders, change in eating habits, or change in how the person talks about their body or their functioning, if you can, being able to have that conversation. I think it's challenging because we oftentimes talk about how unhelpful it can be to comment on someone's challenges or someone's body. And I think especially in the case of if you're a caregiver and you're noticing your adolescent or your child in your care having a significant change in body appearance or food or body attitude, there is a responsibility of, I need to address this. So that's not the most succinct answer to your question. I think what the most helpful thing is to generally have open conversations about how you take care of each other in the family system, and being open about challenges and struggles, and exploring what is this person's capacity for me to provide feedback. Because we do see that even if the parent or the whoever in the family is concerned, bombarding that designated person with concern oftentimes makes them shut down and less willing to seek treatment. So it is a little bit of a dance.
Okay. So let's take that and move it into the sports world, Kendra. And here's my lead in. Okay. In preparation for today, I was talking to a woman who was varsity athlete. She was, I think it was lacrosse. Okay. Clearly, she was a high performer on her team. Okay. She in fact did tell me that there was a distinct tension between the amount of time that she had to spend on the field and training to be on the field, as opposed to the amount of time you were spending at school. It was almost like, the sport, school, everything else, right? And there's a gap here, right? So as I was talking to her, and then I'm thinking about this issue of when somebody needs help, okay, I found that many times those truly committed athletes are listening to their coaches. They're listening to other people. They're not necessarily listening to family, who may be able to identify that there's an issue, may be able to be looking at something that a coach isn't looking for. Because what I'm looking for is, hey, you need to, shave 0.5 of a second off of your time. Whereas a family member may be looking at something else. So how does a family member help in that sports environment? What are they looking for, and how do they raise their hand?
Oh, that's a tough one. I think what's really important for families to keep in mind is that they hold the kind of end of the rope that is about, like, I see you as more than an athlete, and I think that's just automatically, I think, important to come across to any athlete, that, like, I care about you and you're valuable and you're important in this family, whether or not you make this team, whether or not you got, like, that you are so much more than what you produce. And I think all conversations around any concerns, like, need to be grounded in that, and maybe sometimes need to be explicitly, like, kind of stated with that boundary, like, I care about you as a person. And then kind of, I always like the DBT approach of just describing facts. Like, I'm noticing that you're spending a lot of time at the gym, and, I'm just wondering, are you getting enough fuel for that? Like, I know that it's really important for you to be doing more in your sport as you're getting better. And I just want to make sure you have the support that you need. And maybe making, honestly, with athletes, maybe starting with nutrition. Like, what do you think? And like, again, appeal to that athletic identity. Like, what do you think about seeing someone to make sure you're actually eating the right things and enough of the right things to be kind of getting you to that place of being able to perform as best you can for your coach and your team. And so that's what I might suggest, is starting off with nutrition, and don't put it off. Especially with athletes, we may be able to stop a lot of the things that can kind of, spiral into an eating disorder by coming in early, reminding folks that they're cared about and loved and appreciated as human beings, and then reminding them that, hey, like, this is a totally new, like, level of, performance or things that you're getting into. Let's make sure that you have all the support that you need. And that might be the direction I start. As soon as parents maybe start to get that, like, intuitive, like, ooh, like I'm worried about this, trust your gut, your kids.
Okay. All right. I want to be respectful of your time, so I'd like to give you each about a minute to summarize either the conversation or what's important to you or what needs to be said. And I said about a minute because, Kendra, I'm actually going to give you a minute and a half because I want to make sure you mention your book. Okay. So with that, Kathryn, and I also want to make sure you have the last word, so you'll go last. Kathryn, what do you want to tell us? How do you want to summarize?
I think what is most important to me is that we continue to be open to a lot of the beliefs that we have about any group of people, whether it's student athletes or professional athletes or people who recreationally do sports, that we are all struggling with very similar ideologies about body and food and confidence and self-image. And especially in athletes, when literally billions of people may be watching you in the Olympics, that's not normal. That's not a normal level of pressure. And we need to extend compassion and resources, and just is maybe cheesy as it sounds, just view the other person as another person, as your neighbor, whether they're Simone Biles or Michael Phelps. That's a person facing an immense amount of pressure. They might be struggling. How can we change? How can we provide support? How can we better understand what they might be facing so we're not continuing to fuel stigma?
Okay. Kendra?
I totally agree with everything you just said, Kathryn. Love it. I also want to say that I would like to leave people with this message: like, eating disorders are treatable. Like, we have empirically supported care for folks, multidisciplinary care that helps people get better. Don't avoid the problem because you think it's one that can't be solved. Like, eating disorders are treatable, and there are providers who are well versed in helping people navigate through that treatment. And to remember that, they don't look a certain way. So don't think that, like, because someone isn't underweight, they don't have an eating disorder. And so don't judge based on appearance. If someone is or is not going through something, if they tell you they're having a problem, listen to that. Don't be like, well, you're fine. You're not too thin, or you're not too big. Like, don't make, remember that, like, if someone's coming to you for help, that eating disorders look very different. They affect all peoples, all genders, all ages, all races. And so to know that, like, it's not just underweight people who are 14
Okay.
and men. So, like, remember that, again, that I think those two things are super important to remember. And I think also in regards to the book, remember that not all eating disorders have weight shape based drivers. Like, ARFID is a serious eating disorder. It can really compromise people in the same way that anorexia and other eating disorders can. It can lead to incredible levels of malnutrition, micronutrient deficiencies, etc. So it is a real eating disorder. And, we talk a lot about it in the book, the Picky Eaters Recovery book, and how folks can, if they notice any of their symptoms, they can start to read about it and then see what interventions they can even try on their own. But to remember that, presentations of eating disorders aren't always steeped in weight shape-based reasons.
Great. Thank you very much. Let me conclude by saying our sponsor today is Equilibria Psychological and Consultation Services. It is an insurance-based provider whose mission is to help individuals achieve their personal potential and long-term growth by compassionately and respectfully helping clients live in balance. Visit equilibriapcs.com, equilibriapcs.com. You can look for them on Facebook, Instagram, and LinkedIn. You can also look for me on Instagram, Daniel J. Gomez 24, and on LinkedIn. Now for the disclaimer. I am not a medical professional, and I am not providing medical advice. The opinion of our speakers is solely their own. This podcast is copyrighted and cannot be reproduced without the express written consent of EPCS Management, LLC.